Welcome to our final seminar in the Health Terminology Standards seminar series. My name's Linda Bird. Most of you have met me, but for those who haven't, I'm an adjunct assistant professor here at the University of Victoria, an active implementer of healthcare interoperability standards, and the instructor for UVic's HIMP 597 course, which is hosting this HTIS seminar series. And by the way, HIMP 597 is the field project in health informatics. Before we get started, we would first like to acknowledge and respect the Lekwungen peoples on whose traditional territory the university stands, and the Songhees, Esquimalt and Wasanich peoples whose historical relationships with the land continue to this day. So, as I said, today is our last seminar in the Health Terminology Standards seminar series, and we're very lucky to once again have Derek Ritz with us. Derek joined us last week to talk about computable care guidelines, and this week he will explain what the Buildable Digital Health Blueprint Toolkit is. Please note that all the presentations in the series are recorded and shared on the school's website. And just a quick reminder, if you're interested in enrolling in our September intake for the Certificate in Health Terminology and Interoperability Standards, applications close next week on Monday, July 15th. This is a one-year part-time program with 4 graduate level courses, including this one, which are done through weekly online evening classes plus a virtual workshop. It's the only terminology standards program in Canada that's accredited by CHIMA, the Canadian College of Health Information Management, to become a certified terminology standards specialist in Canada. So I'm sure all the students are looking forward to that. To find out more, quickly scan the QR code or visit the school's website. And please remember, Monday, the applications for next year close. And so it's with my great pleasure to once again introduce you to Derek Ritz. For those of you who didn't meet Derek last week, Derek Ritz is the principal consultant at EC Group Incorporated, which is a Canadian professional services firm that provides expert advisory services to domestic and international public and private sector clients regarding digital health strategy, architecture, standards, implementation, and adoption. So with that, I will pass the floor to you, Derek, for your presentation. Thank you so much for joining us again. Over to you.
Thanks, Linda. And I'm going to start sharing my screen, and let me just get confirmation that, in fact, people are seeing the Buildable Blueprint Toolkit.
Yes, we are.
And in full screen show mode.
Presentation mode.
Presentation mode. So I'm also, if you can still see me, going to begin by just saying a very heartfelt Go Canada. 6 minutes ago, they kicked off against Argentina in the semifinals of the Copa America, and I wish them well. So on to...
I owe him for still being here today. So thank you, Derek.
Our topic is the Buildable Blueprint Toolkit. And this is a project that I've been doing over the last couple of years with the World Bank. Again, my mandatory apologies. As fellow Canadians, you know this is just the perfect way for a Canadian to begin a presentation, with the pre-apologies even. This particular presentation is made up of presentations that I've used over the past couple of years as myself and my World Bank teammates have presented in Washington, D.C. at the Global Digital Health Forum, at the PMAC conference in Bangkok, at Fire North, which was held in Hamilton last fall. And so this is a kind of a Franken seminar that's an amalgamation of various decks that I've used and my teammates have used over the course of the last while. The story arc for today, again, I think everybody had a chance to be briefly introduced to me last week, but I'll pull up my introduction page again, and then we'll go through why do we, and I've put we in air quotes, why do we need the toolkit and what exactly does it do? And then I'm going to try swinging without a net, and I'm going to spark up the spreadsheet. And instead of doing screen captures, which is what I've typically done in presentations, I'm actually going to play with it live because I do want you to see one of the quite differentiating aspects of this toolkit. And it is that there is a 10-year investment case that can be developed. One of the things that Linda and I were talking about just before we got started is that for World Bank, which is a multilateral lender and donor, this is exactly the kind of thing that they need to see. Because if you're doing a pilot, you need $1 million here or a couple of $1 million there, and there's all sorts of places that you can find $1 million. But if you're going to roll digital health out across the length and breadth of your country, depending on the size of the country, you might need $100 million. You might need $250 million. And now you're going to be approaching the multilateral lenders like Asian Development Bank, like the World Bank. And this is that. This is a way to model and say, okay, this is what I'm going to do. It's going to take me years. I've got thousands of facilities and tens of thousands of health workers, but my burden of disease is going to be ameliorated by my digital health investments. And it's a way to see what that's worth. And there's an economic modeling method that's quite mature, and we're going to play with it a little bit. So that's the kind of the latter half. Okay, I think all of you who were here last week saw this slide. This is my my slide of disclosures. So I have done work domestically. I do still do work domestically and in the EU. I live half time in Paris, half time in Toronto. But most of the work over the last 13, 14 years has been in low and middle income countries for the folks at the sort of top right of the screen. So for the World Bank and for WHO and for the Gates Foundation and for UN Ops and UNICEF and others, Asian Development Bank. I was an advisor to ADB for 3 years. Here's the thing. This toolkit arises out of projects that I did. Now, I've done national scale blueprint projects in almost all of the countries, but I've really started refining it and started developing a toolkit that I used when I had these engagements. And I've used it and reused it in the Philippines, in Cambodia, in Myanmar, and Linda and I were just talking about Myanmar right before we got started. Both of us, I think that's probably the last conference we were at together, and in Iran. And in Kosovo, sorry, I'm still in the petulant throes of doing the project in Kosovo with my World Bank teammates. So this is very much reflective of lessons learned over the course of the last few years on these country projects. So what is the toolkit? It's a set of PowerPoint decks and Google Forms and Word documents, plus a whole how-to guide that says how you would use these templates. And these templates are to be leveraged by a facilitator who's working with a local technical working group struck by the Ministry of Health that has been tasked with developing and publishing a buildable digital health blueprint. This particular one is based on the HL7 fire standard. I have 0 clients right now that are interested in using anything except the HL7 fire specification. I know that there are other approaches, HL7 version 3, HL7 version 2. There's the Open EHR family of specifications, but all of the work that I've been doing is based on HL7 fire, and I think that's because WHO has kind of leaned into that as the approach that they're going to be following. And in so many low and middle income countries, that's the they follow the WHO country office when it comes to matters like this. So that's what the toolkit is. So this is a set of slides that we used at Fire North that address the burning question, why should we care? Why is this toolkit important? So the World Bank has a mission, and you can go to their website and see what their mission is. And a core element of the World Bank's mission, and this is true for all of the big multilateral lenders, is that they want to address health equity issues. So the graphic on the left is a map of the world reflecting income. And as you see in dark green, Canada and the United States and Australia and most of Europe are dark green, high income countries. And then you can see on the other end of the spectrum, light purple and dark purple being lower income and low income countries. So that's the world represented, categorized by income. On the right-hand side, you see the world categorized by burden of disease. And here, again, you see Canada and Australia and much of Europe as very light yellow, meaning we've addressed our burden of disease. I mean, it's not like there's zero TB in Canada, but there's almost zero TB in Canada. It's not that there's zero HIV in Canada, but there's almost zero HIV in Canada. Our burden of disease tends to be chronic diseases, tends to be COPD and ischemic heart disease and diabetes. But look at sub-Saharan Africa and look at some of the parts of South America and Asia Minor. I mean, these countries, which comparing the left and right, these are the poorest countries and they have the tallest burden of disease. And so there are real health equity challenges. And the going in proposition is that we can leverage digital health to improve health. And that was one of the topics that I was harping on last week. Now, over the last decade, digital health investments in low and middle income countries have generally focused on the collection of aggregate indicators. Software applications such as Digital Health Information System, DHIS version 2, have been broadly implemented, and it was, heavily supported by the donors, but they weren't for care, they were for statistics. And one of the reasons why donors, and WHO among them, even though they're not an especially strong donor, they have a voracious appetite for aggregate indicators. WHO is addicted to aggregate indicators. And so investments in digital health were made in collecting statistics in these poor countries, in these low and middle income countries that have such a heavy burden of disease. And I was an advisor for 8 years to the US government's PEPFAR program, the President's Emergency Plan for AIDS Relief. And I was like John the Baptist. I was a voice in the wilderness because they were heavily investing in the collection of statistics because they had to report to Congress every year so they could get another $7 billion to be spread across the 53 PEPFAR countries. And I was telling them that what in fact they should be doing is focusing on the front end, that they should in fact be investing not in collecting better statistics about just how, they shouldn't be more precisely measuring how dysfunctional the care delivery network is. They should be investing in improving the functionality of the care delivery network, improving the ability to execute the health production function. And I advocated for this. I told them this is a smart thing to do because if we leverage things like computable care guidelines, which I talked about last week, we can actually improve the adoption of evidence-based best practices across the entirety of the care delivery network. And if we're collecting person-centric information, we can still get indicators. We can automatically generate indicators from this person-centric data. And when we frame the problem this way, what we end up getting is a capacity increase to be brought to bear in terms of care delivery, because all of that aggregate indicator reporting was parasitic on the nursing staff. They spent a huge amount of time, and by a huge amount of time, I'm talking about 5-6 hours a week. You're looking at something that's approaching 20% of the capacity of nurses being spent on aggregate indicator reporting. So when we start to do this, if we start to arm them instead with digital health tools that improve their efficiency and their effectiveness and their ability to deliver care, not only do we get that benefit, but they don't do the aggregate indicator reporting. And this actually creates capacity. Now, the role of the toolkit is to help support the re-engineering of the care delivery network, to say, instead of it being kind of a little add-on somewhere, we're going to assume that digital health tools are going to be foundational in how care is delivered. And so important implementation and investment plans get informed by the outputs from this toolkit. Now, this platform idea is part of the big deal. It's part of the big story. It's part of why World Bank is interested in this. When we're starting to talk about going to scale, and there's a new initiative led by WHO, they seem to be in love with this two eyes thing. So the dig is being overtaken by the guide, and the guide is this global infrastructure investment for health idea, for digital health that WHO is behind. This platform play, the idea that you won't put an app out there for doing malaria, you'll put foundational platforms in place that are used for everything. And that's very much at the heart of this. In order to get a systemic impact, you're going to have a systemic rollout, a system-wide rollout. So the key takeaways here, we can adopt digital health as a way to improve person-centric care. We still get indicators from that. But we actually will never have more chickens by counting them more carefully. I've just quoted my grandfather on my mother's side. You will not have more chickens by counting them more carefully. You can't statistics your way into improving the outcomes for your population. You have to actually deliver health better. Now, person-centric data can be leveraged to automatically generate these indicators, and that reduces health workers' burden. It's a great outcome. And the role of the toolkit is to help create the implementation and investment plans around a broad, scaled re-engineering plan for the care delivery network. All right, I'm storming through this as best I can because I actually think that the investment case part is going to be very cool. But let's talk about it comes at the end. Let's talk about the process that the toolkit follows, and we'll get there. So the toolkit is leveraged to facilitate the efforts of a TWG, a technical working group. This is a short duration project, a couple of months. The Kosovo project we just did was 9 weeks. For those of you that might remember, I was nursing a cold last week, and I'm almost entirely over it, but apparently not completely over it. So a short duration project. Now, just to put things in perspective, when Canada Health Infoway went through the blueprint version 2, it took 2.5 or 3 years. These projects take 9 weeks or 10 weeks. The idea is not to spend 2.5 or 3 years talking about this. And I don't want to pretend that there wasn't all kinds of useful aspects of the process that Infoway went through. But I have to admit, as I'm starting to get older and older, I'm feeling, that I've got a theme song. There's the Elvis Presley song ringing in my ears at all times. A little less conversation, a little more action. And honestly, this is about working with the technical working group to get moving forward, to overcome the inertia, not to talk about it and talk about it and talk about it. You talk about it for months and months and years. No. This is to make the decisions, to get the investment, and to go. And the artifact is a buildable digital health blueprint. It's actionable. Many of the countries that Linda and I work in, the low and middle income countries, have had a blueprint for 10 years, but it's like this placemat. It's a picture. It's like the artist's rendering of what a building would look like if you ever built it, and it's got trees drawn in front and somebody's walking their dog. No. That's not what this is. This is not the artist's rendering of your health enterprise architecture. This is using the construction analogy, this is the carpenter's drawings and the plumber's drawings and the electrician's drawings. This is how you make it go. This is the actionable stuff, including, importantly, an investment case. Now, the TWG should be pulled together from all kinds of different perspectives. That's really important. There's something that Linda and I were involved in helping launch in the Asia eHealth Information Network in the Asia Pacific region called convergence meetings. And the convergence meeting was hosted by the Ministry of Health, but then they would have the Ministry of the Interior and they'd have the Ministry of Finance. And although Asia Development Bank was often funding it, there would also be the World Bank would be there, and KOICA, which is the Korean investment donor group, and JICA, which is the Japanese donor group, and it would have NGOs that are working in country, and WHO and UNICEF and others. The idea of the technical working group is that it should be bringing all kinds of perspectives to the table. That's really, really important. The toolkit supported process will work to align digital health tactics to strategy. This is about, as I said, this is about it being go time. So the first thing, as with any IT project, you say, well, what's this for? So the first thing to look at is what's the country's burden of disease? And even South Africa, which for ages has been the poster child for infectious diseases because it had such a heavy HIV burden, South Africa has got a taller non-communicable disease burden, a taller chronic disease burden than their infectious disease burden now. And that's just because as any country gets wealthier, and South Africa is actually, in sub-Saharan Africa, it's probably the wealthiest of the countries, you shift from communicable diseases to non-communicable diseases. That's the truth. So what's the country's burden of disease? What's the current health system strategy? And do a quick check and see if it's well aligned to the burden of disease, because if it's an old one, maybe it isn't. What's the current digital health strategy? And see if it's aligned to the health strategy and see if both of them are aligned to the burden of disease. And then look at how digital health can make an impact and what would be the conformance testable infrastructure elements that are needed. And I leverage this metaphor of Lego blocks. You want to have blocks that click together. You want the dimple pattern on the top of all of these digital health elements, architectural elements, to click together. I have long been an advocate for boring being the most important element of your digital health infrastructure. You don't need the coolest thing. In fact, you shouldn't be the least bit interested in the coolest thing, because the thing that's cool is to go to scale. And if you're going to scale in a low resource environment, you can't be fiddling around with your software all the time. You can't be fixing bugs every midnight and thinking you're going to do a new build and that somehow magically that's going to change what you've implemented across the length and breadth of the country. You need conformance testable Lego blocks that click together and work. So the fourth bullet is talking about a health enterprise architecture and the infrastructure that it describes and how you actually construct it. Then we're looking at the investments that have already been made in the country and saying, well, where are we now? And how do we get from where that is to a future state where all of the things that we have are plugged into this national scale data sharing infrastructure? And then, so these are set up into workshops. The first three bullets were the first workshop. The fourth bullet is workshop 2. The fifth bullet is workshop 3, saying, how do you go from what we have to what, how can we use what we have? And then the last one is focused on implementation science. And it often can be 2 workshops or even 3 workshops, because honestly, when you talk about implementation science, you're talking about how are you going to go make this happen in the world? And making things happen in the world is where you get your scar tissue. This is where you're at the clinics, and this is where you're doing the hearts and minds work for all of your health workers, and in some cases educating them around data use and why they should love digital health. This is graphically how it plays out. So in the top left corner, you see your faithful facilitator who does all of the preparation work and the research work and who helps facilitate the work of the technical working group in these iterative workshops. Typically, as a facilitator, and I played that role quite a few times, you would prepare homework material for your technical working group members, and you would send that ahead, some reading material for them to look at ahead of time. You would leverage PowerPoint decks to to move people through a guided, facilitated discussion, but then you would get their input from Google Forms. One of the great things about Google Forms is A, it's free, and B, you can have people fill in the form and you can see in real time the pie chart or bar chart or line chart or whatever it is that's captured their information. And we would then discuss it and we would achieve a consensus around information that then ended up in the blueprint. So there were decisions to make, and that's how we would capture the wisdom of the team and reflect those decisions and faithfully tell back to them at the beginning of the next workshop. Here's what we decided in workshop 1. Now let's move on to workshop 2. And then here's what we decided in 1 and 2, and let's move on to workshop 3. And it really built a good momentum. And it was pedagogical in some ways because not every member of the technical working group was somebody who was well versed in health informatics. But if you were there because you were clinically trained and you were bringing that perspective, you would learn a little bit about health informatics that you didn't know before. And the perspective that you brought would inform all of the technical people about some of the ground truths that have to be abided in this new national scale infrastructure. So the toolkit would be the facilitation aids, sample PowerPoints and Google Forms, and a skeletal blueprint document with annotations, and a great big spreadsheet, which is what I'm going to be showing you later. The World Bank is a bank. They expect to get a return on their investments, which means they have to be serious about mitigating risk. And they actually spend a lot of effort on that. When they're making a $250 million investment in the Ministry of Health, they do look for gated funding and they do look for reporting. And, some of these states have got high corruption levels and they do look for there to be audit trails for where the money went and all these things. So the toolkit leverages global norms and standards and conformance testable architectural patterns because it mitigates risk. Linda, I don't know if you remember, but I had a shtick that I did at some of the AHIN meetings, which are these Asia eHealth Information Network meetings. And there'd be hundreds of people in a hotel conference room, and I would wear a T-shirt underneath my suit, and I'm a little bit old school, so I always wore a suit to these events. And I would start to take off my jacket, and well, everybody knew I'm Canadian, so it's a hot country, so that didn't surprise anybody. But I'd start unbuttoning my shirt while I'm giving my presentation and do this kind of strip tease thing, and then I would pull open my shirt and take off my shirt, and I had a T-shirt on underneath that said, "Boring is best." I have long believed that countries were not well served by this kind of magpie idea that they should be going for the shiny new object. And I can tell you that, FHIR has been around for a few years now and is starting to show some maturity. But for a while, it was the shiny new object, and it was risky, super risky. And myself and a small group of others worked in a standards body called IHE to take FHIR resources, to take FHIR standards, and to profile them and to take all the fun out of them and to make them boring enough that they were like these little Lego blocks that could be relied upon and that could click together and be part of an overall infrastructure. I really believe that this risk mitigation aspect is something that is astoundingly important in all of the low resource environments that I worked. It's astoundingly important in Canada. Canada has now adopted the IHE methodology as our way to de-risk our efforts around the National Patient Summary Initiative, for example. And we're doing projectathon testing every year where these now boring Lego blocks can be demonstrably clicked together with different vendor products, and they can show that they've got the dimple pattern on the top of their Lego block and that they click together with everybody else, and that it can be a new toy every day, but not because we're making up the Lego blocks, because we can configure them as we need to configure them to be sensitive to what differences there might be between the care network in BC and the care network in PEI. Okay, This is a busy diagram, and I get that it's a busy diagram. This is a generic infrastructure diagram. So as busy as it might look, it's in fact just a little bit of an expanded view of something called the Open HIE blueprint. Open HIE because it's open source, HIE for Health Information Exchange. And Open HIE is a now 11 or 12-year-old initiative, donor-funded initiative that myself and a few colleagues helped launch in 2012. So this, for some of you, might look a little bit deja vu-ish because it looks a lot like the Canada Health Infoway Blueprint version 2 from 2006. That's intentional. That architectural pattern is in fact a mature pattern that works, and this this kind of notional generic blueprint for a health information exchange is based on that. Now, I was mentioning that you get a running start. If there are existing digital health solutions, how are we going to be able to plug them in? There's something that called a facade pattern. Any of you that have worked in software development for a while might have heard of a facade pattern. And that's where you take a solution that isn't standards-based, you don't break it. You put a facade on the front of it that takes whatever the application programming interface is that the software has, the non-standards based API, application programming interface, and you transfer it or you translate it into the standards-based one. So if there's a client registry that you've already been using, we had one in Myanmar, PMRS, that had 8 or 9 million Cambodians in it already. Wonky as a $3 bill, absolutely zero adoption of standards. But we were able to put a fire facade in front of PMRS, and it could play the role of a client registry. And that was very helpful. That gave us a real running start, as an example. The investment case leverages this idea of activity-based budgeting. So the way that you work up your cost model and your benefit model, I'm going to go backwards for a second, is you say, if you have underlying health worker directories or facility directories, and you're pulling this information into an interlinked registry for health workers and facilities and organizations and health services, a database of health services, your terminology service. If you have these and you have to be able to build interfaces and connect them in, or if you have point of service, that's what POS stands for, point of service solutions for your labs and your pharmacies and your electronic medical records, and you have multiple electronic medical record systems, the way that you drive your costs is to say, well, how many of these point of service solutions do we have? In how many facilities have they been implemented? What proportion of the facilities don't have anything yet? And so where do we have to do net new implementations? Where do we have to do facades, and so on and so on? And you just tally all of that up and say, well, it'll cost about this much per facade, and this much for a little facility, and this much for a medium-sized one, and this one for a big one, and so on and so on. And you do activity-based budgeting, saying what's the quanta of how much stuff I have to do and how much is each going to cost. The reason that this is illustrated this way is in the middle is your care delivery network. And the care delivery network executes the health production function. You put money in, you get health out. And what you want to be able to do is develop a cost model and say, this is I'm rolling out digital health across the length and breadth of the land. Here's how many facilities there are and how many health workers there are across the length and breadth of the land. And remember, we talked about burden of disease, and this is the burden of disease I'm going to address. And you can get that burden of disease expressed in disability adjusted life years or quality adjusted life years. One is the reflection of the other. And you can say, well, this is how much money I'm going to spend, but this is how many disability adjusted life years I'm going to reclaim. I'm going to ameliorate the effects of ill health. I'm going to improve health outcomes. So for this amount of money, I'll get this amount of health. And is that a good buy or not? Does that provide me with a return on my investment or not? And there are models that give us a way to measure that. I'm going to pause for a second. Does everybody know what a disability adjusted life year is? Before I keep going, it's an important conceptual thing. Or does nobody know what it is? Or if there's anybody that doesn't know what a disability adjusted life year is, please can you just let me know, and I'll go into a brief explanation of them.
I'd like to hear the explanation.
Okay. So the premise is, if I live a year in full health, my quality adjusted life year is 1, and my disability adjusted life year is 0. And that's why I said the two are a reflection of each other. So I had 0 diminishment of my enjoyment of life due to my ill health. Now, if I'm diabetic and I am and I'm suffering blindness, or I've had a foot amputation, there could be all kinds of things that can quite significantly diminish my enjoyment of life. And so you would say the disability adjusted life year would be, and there's ways that this gets measured, and in fact, McMaster University in Hamilton has done some of the leading work in this. But you might say, okay, well, I've got a diminishment of 30% of my quality of life has been diminished by the disease that I have. And so you would be losing, oh, I should have picked something I can do in my head, 25%, let's say 25%. So that means out of my year of lived life, I have a disability adjusted life year of 3 months, which means my quality adjusted life year was 9 months. And you can think of it that way. Out of 1 calendar year, because of my ill health, I got 9 good months. And so a quality adjusted life year, or you avert disability adjusted life years to increase your quality adjusted life years. And one is the complement to the other. And so what you want to do is say, I want to ameliorate the effect of poor health. And the premise is, because of last week's, you might recall from last week's session, if I can improve adherence to care guidelines, I'll get better health outcomes. And if I get better health outcomes, my measure of that, my quantified measure of that, is I reduce the DALYs that I lose. So if somebody stays on their meds, is following their guideline-based behaviors for good, healthy behaviors, then you can live the whole rest of your life with type 2 diabetes. And in fact, lose very little in terms of your DALYs. But you have to be adhering to the best practices. You have to be following the course of care for diabetes, because you manage a chronic disease and you keep somebody out of the emergency room and you prevent them from going blind. And you do a foot exam every year so that you don't end up with an amputated foot, and. So improving adherence to care guidelines reduces the DALYs lost, increases the quality adjusted life years. That took longer than I thought it was going to take, but how was that, Debbie?
Yeah, that makes sense. Thank you.
There's a very mature way to measure DALYs and QALYs. And in fact, the Institute for Health Metrics and Evaluation, IHME, at the University of Washington in Seattle, is a WHO collaboration center, and that's their day job. They, for all of the countries in the world, are gathering the data and crunching the numbers, and every few years they update the disability adjusted life years and the causes of those DALYs for each of the countries of the world. Now, we talked about this before. This is the This is the, we're not dabbling here. We're taking this to scale. So the toolkit very much has a whole health system scope. And importantly, that includes the private and the public sector. And that might sound like, oh, well, of course it does. In many of the countries where I've done work, the Ministry of Health or the Department of Health has very little power over what goes on in the private sector care delivery network. And when I was doing work in the Philippines, for an example, over 60% of the care, on a peso basis, over 60% of the care in the Philippines was actually delivered by the private sector. And the Department of Health had no line of sight into that and really exerted almost no governance over that private sector care delivery network. And that is something that in the ensuing years, so I was there, I think in 2016, that has fundamentally changed in the time since we did the work there on their national digital health blueprint. Importantly, because PhilHealth, which is their national health insurer, has started steadily expanding its scope of insured services. And now, private sector is all about money. I'm sorry to put it so crassly, but the private sector is all about money. And you now can exert some governance over them because they want to be providing those insured services. And PhilHealth, as an arm of the government, as an ally of the Department of Health, gives that lever, gives that instrument of governance because they're paying for those insured services. Okay. What are the key takeaways here? It's expected that Toolkit will be leveraged by a multi-stakeholder TWG, and it's expected that this is going to be a short duration project. This is not years and years and years. This is a little less conversation, a little more action. The TWG aligns tactics to existing digital health and health system strategies, and it's easy for me to say, an implementable, conformance testable digital health specification will be developed as the base of this. Now, make no mistake, this typically becomes the national norms and standards for digital health for the country. I am one of the primary authors of the National Norms and Standards for Digital Health in South Africa, the National Norms and Standards for Digital Health in Myanmar, in Cambodia, in Kosovo, in Rwanda, in Kenya. That is one of the outcomes of these blueprint efforts. You publish a national norms and standards for digital health for the country. And the fact that it's conformance testable means conformance testing is now an instrument of governance in the hands of the Ministry of Health. Very powerful. International best practices are leveraged. That mitigates implementation risk. So we are using global specifications, IHE profiles mostly, because they're all of them conformance testable and they all click together. The investment case develops your dollars per dollar metric over a 10-year planning horizon. It's important that it's over 10 years because you could spend 3 or 4 or 5 of those years doing your national rollout. And you want to have been able to operate that way long enough to see what the impacts are going to be. So what are the outputs from these meetings? It's sort of 3 phases. The first of the outputs is that there's a contextual analysis. We look at what are the published strategies for digital health and the published strategies for the health department. We look at what are some of the common best practices in other countries, and we look contextually at how digitally ready we are in the country that's going through the blueprint effort. In the middle, we do the work of saying, okay, I want to be able to embrace international best practices, and if I can do that, I mitigate risk. And there's this kind of hierarchy, and it's actually the one that Canada Health Infoway adopted in 2001. As the first preference, we want to adopt international best practices. As a second to that, if we can't just adopt it out of the can, we want to be able to adapt something. And we regularly had to do that in Canada because many of the specifications coming from HL7, for example, were unilingual. They just were not contemplating that you'd have to be able to operate in 2 languages. So in Canada, we very regularly had to adapt because we had to be able to work in French and English. And as a distance, third option, we want to develop. So adopt if we can. If we can't adopt, adapt. And if we can't adopt or adapt, as a distant least preferable option, develop. So in the middle, the first part was context setting. In the middle, we're looking at whether or not we can adopt. And if we can't, whether we can adapt. And I'm happy to say, I don't have any countries that I've worked with that have had to get into the standards writing business. And one of the reasons I tell them that is because, I mean, I was on a call in Myanmar, and I said, listen, guys, we've got the entire bench strength of health informatics professionals for Myanmar on this call. There's 36 of us, and we're it. If we make any changes to these standards, we're the ones who own that. And I was advising them, and I said, I can tell you, we don't need to do that. But if you think we have to do that, just so you know, that means somebody on this call should put up their hand and say they're going to babysit this specification. Because when you get into the standards writing business, it's not a one and done. You actually have to now create a national standards body that's going to own this for the rest of time. And mercifully, we made zero. This was, in fact, at the time, the International Patient Summary. We adopted the IPS with 0 changes, which was perfect because it worked and we didn't break it. I can tell you with a bit of a broken heart, with a real catch in my throat, we in Canada have way too much money because we almost always, and I will tell you the Ministry of Health in Ontario is guilty of this, so guilty of this. We will almost always start jerking around with standards that we could just adopt and move on. But no, we've got a very strong health informatics bench, and we feel it would be just terrible to not use them by taking things that already worked and now start fiddling with it and making ourselves idiosyncratic when we didn't need to. And I know that sounds harsh, but it is a reflection of how wealthy we are. That conceit is a reflection of how wealthy we are. And one of the things that I have learned in working in so many low resource environments is we waste an astounding amount of money and time, and we don't need to, but we do. Part 3 is at the far right-hand side of the screen. And that's where in the implementation science workshops, we say, okay, what are some of the ways that we're going to approach this? And what will that mean for how quickly we're going to be able to move? And what are some of the choices we've made around things as simple as ID cards? Because everybody in the country gets one of those. And how has that driven costs? And if you look at the amelioration of disease and what our burden of disease is, our costs versus our DALYs gives us a cost utility analysis, and we can get a return on investment graph from that. So that's at the far right-hand side of the screen. Now, in many countries, they don't have in place the legislative frameworks and the consent directives, the default consent directives that we have in Canada now. But this is a lot of the work that we had to do. I remember when PHIPA, the Ontario health data privacy legislation was brought in. That was 2006 or 7 or something like that. So this isn't that long ago. But many of the countries that I work in, that's part of it. We have to say, well, is there a legal basis? Do you have defined entities? And do you have defined behaviors for those legal entities? What is your consent, your default consent directive? And many people think, oh, well, it can be opt-in or it can be opt-out. It can't be. Theoretically, it can be. One works and one doesn't work. It should always be, always, always, always. It should be an opt-out consent framework, always. And I do, as I said, I do a lot of work in Europe, and I have people look me in my beady little eyes and they say, well, no, I want to be able to, I should have my rights as a European to, um, no data should be shared about me without my consent. Yeah, except in healthcare. In healthcare, you have an expectation of patient-safe, high-quality care. And in order to get patient-safe, high-quality care, your data has to be shared with the people in the care delivery network. And so that should be the default. You can withdraw your consent to have your data shared. You can't withdraw your consent to have your data collected. You can withdraw your consent to have your data shared. It has to be collected because we have mandatory reporting. If you've got Ebola, we have to be able to report that to public health. You can't withdraw your consent to have your data collected because the physician that's providing care to you has medical legal requirements that they can't forego. So they have to have health records that they maintain, and they have to be able to do billing. So your data will always be collected. And for the purpose of delivering care to you, so for that defined purpose of use, your data will be shared with the people that are in your care delivery network by default. And you can withdraw that, because if you can't withdraw your consent to have your data shared, there's no such thing as privacy. I was one of the 3 primary authors of Canada Health InfoWay's national privacy and security architecture. So at one time, 2008 or 9, I think it was, I had access to the data and I had access to Ontario's data. And at that time, we had 12.5 million people living in Ontario. It's about 14 million now. And of the 12.5 million people, 53 had withdrawn their consent to have their data shared. That's very consistent with the kind of numbers you see internationally. Singapore has a national health information exchange with 6-point-something million people in it, and a little under 400 have withdrawn their consent to have their data shared. It's not something that happens very much. But if you can't do it, if you can't withdraw your right, if you can't withdraw your permission to have your data shared, there's no such thing as privacy. So these legal frameworks and this governance aspect has to be in place. And the toolkit has some defaults to help people that aren't well set up in terms of their legal basis to get themselves well set up. The bottom right, by the way, this is something that the Ministry of Health, we encourage them to do, because in many countries that are receiving a lot of donor aid, donors come in with buckets of money and they have their own little initiative and they're doing it. And it's very patronizing. And I say that because the ministry is in fact not coordinating all these efforts. The donors are. UNICEF will be in there doing an immunization program. And you could say, well, wow, how could you be against that? Well, I'm not against that. I just don't think it should be siloed. And then PEPFAR will be in there doing an HIV program. I'm all in favor of doing HIV care. I just don't think it should be siloed. The President's Malaria Initiative will be doing a malaria project. Stop me anytime. All of these things are not under the governance of the Ministry of Health, and they should be. And one of the things that I help people do through this toolkit is establish a program management office that governs and does conformance testing on all the projects in the country, whether they're being funded by the ministry or not. If they're being funded by other donors, if they're being funded by universities, doesn't matter. Everybody works under the auspices and under the governance of the Program Management Office. And I've been happy to say that my World Bank teammates are totally on board for this. Not all donors are as much in love with that. I can tell you that sometimes the American donors, the PEPFAR program, is not usually keen to subject themselves to the governance of the Ministry of Health. Now, to be fair, some of these ministries are not especially strong in exerting that governance. But you should do the capacity building and help strengthen them. You shouldn't just say, well, listen, I've already got a bunch of people that I can fly over from Washington that know how to do this, and we'll let them do it. And they'll, we're reporting to Congress, not to you guys. No, it should always be when you're working in the country, you're under the governance of the Ministry of Health. Something called the Paris Declaration that commits countries to work that way. And Canada does a good job. Our digital health, actually all of our aid is untethered aid. As I mentioned, the United States is very often tethered aid, which means they decide where it goes. They follow the money all the way down to where it gets spent and on the things that get done. I said that there's a lot of implementation science focus, and there's a couple of aspects of implementation science I want to tease out here. One, you should put in your HIE first. First of all, you should put in an HIE because it saves you the permutations and combinations problem of having to connect everybody to everybody else, point to point. So there should be an HIE, but you should put it in first. And the reason you put it in first is because you get a network effect. I had huge pushback on that idea in South Africa when they said, well, there's no ribbon cutting when I put the HIE in first because nobody's connected to it yet. And if you remember, some of you might remember, many of the investments that Infoway was making in the period sort of 2005 to 2012 or 13, there were these repositories and registries and things that were getting put in place, but then there wasn't much traffic on it. That was the case in the UK. I remember people talking about what a big debacle that UK investment was because they put in place the spine, but the edge of the network wasn't ready. So the fact you had the middle in place didn't matter. And a lot of people walked the plank on that project in the UK. They were made, it's career ending for some people. And how unfair is that? Because as of November 2019, there's more traffic on the NHS spine. The National Health Service in the UK is called the NHS. There's more traffic on the NHS spine than there is in the banking network in the UK. Put the HIE in first, because then when you implement at a clinic, doesn't matter. When you implement at the second clinic, still didn't matter because for the same amount of effort, they could connect to each other. But when you implement the third clinic, you're enjoying a network effect. And at the 30th clinic and at the 300th clinic, everybody who connects to the HIE is connected to everybody else who's already connected to the HIE. And you get this geometrically increasing value proposition, and that's what the network effect is. So put in the HIE first because it gives a real energy, it builds real momentum as the implementation progresses. In the bottom right, I'm showing critical slice implementations. If you have to implement something first, we'll implement an entire referral network. All of the little clinics, the district hospital, and then the regional hospital. And that way, you can do an entire course of care. You can do diabetes care, actually, if you put in place the clinics through the referral network, and then you put in pharmacy and you put in lab. Now you can do diabetes care, HIV care, all kinds of things where the course of care is to do lab tests. If you're diabetic, you get your HbA1c, and if your HbA1c is not well controlled, you're given a course of medications. So you put the clinics, pharmacy, lab, and then you put a referral network in. If you have to do something first. So if you do a critical slice implementation first, even if you're doing a 4-year or 5-year implementation plan, you might have stuff that's lit up and working and delivering benefit after 18 months or 20 months. So do critical slice implementations. There's elements of implementation science that can make a real difference and have a really positive impact. This is what the example table of contents looks like on this blueprint when it does get published. And it documents faithfully what came out of the workshops. This is what the burden of disease is in the country. This is what our digital health readiness is. This is how well aligned our digital health strategies and our health strategies are to each other and to the burden of disease. These are the norms and standards for fill in the country, for Kosovo, for Cambodia, for Philippines, for South Africa, for Myanmar. here's our digital health landscape, and here's some opportunities to put a facade on, in Cambodia, to put a facade on PMRS and have 8 million people in the client registry, just like that. Here's our plan for human resources for health. I had to change, I do HHR, Health Human Resources, but the World Bank says, no, it has to be HRH. And I said, man, I just can't not see that as His Royal Highness. I'm Canadian. We've had a monarch for the whole time I've been alive. So that's human resources for health, capacity building, how we're going to do governance, and then as appendices, typically an example use case and the 10-year investment case. That's what the blueprint output looks like. That's the published thing. All right. How am I doing for time? 9 o'clock. All right, I'm going to go like Deputy Dog now. So the key takeaways here. The outputs are actionable artifacts. This is the stuff that you use to make investments and start to build things, start to procure things, start to set up a server farm and start to get the servers warm. The contextual analysis aligns the tactics to the strategies and the deployments and gets you from the where you are to the where you're going to go. The buildable, conformance testable, standards-based specification becomes the norms and standards for the country. And the way that that gets configured is reflective of the context. Not that you needed separate Lego blocks, but how you click them together is reflective of the context. There's a notional project plan, and that drives the investment case. And over a 10-year horizon, that can help support the decision-making and gives a sense of what the anticipated benefits would be. And where it has to be done, there can be recommendations made to the Parliament around the governance and policy that has to be adopted to be ready for digital health at scale. And I can tell you that's been a key part of every project I've done. It was a key part. There was legislation that had to be adopted by the government of the Philippines before they could move forward. By the way, legislation, they had to change their consent, their default consent. When I was there in 2016, I said, here's an implementable blueprint. You can't implement it yet. You have to change your legal basis for a national health information sharing infrastructure. And until you do that, you're not going to be able to get traffic on this HIE. And it took years. It took 3 or 4 years for them to make the change in the legislature. And when they did, they could actually start to move forward. I rattled along for a long time without pausing for Q&A, and I'm very sorry about that, but I'm pausing now. Are there questions?
Any questions? I don't see any in the chat. If anyone wants to speak up, you can now. I think you might be good to go, Derek.
Then go I shall. All right, I'm just going to take a moment to go through the technical foundation of this HIE design, because the cartoon version of that cloud diagram that you saw before is this, which is the Open HIE blueprint. This has been adopted by over 60 countries. This is the foundation of their health enterprise architecture. The data that drive the investment case and where these data comes from is, we need to know what's the current readiness. How many health workers do you have? Are they digital ready? How many people are there in the country? And what kind of health IDs do they have? And this is now mapping to the client registry and to the health worker registry and the overall architecture and so on. So the investment case content comes from the workshops, and the organizing framework is the Open HIE blueprint. And in workshop 1, we start to tease out what's the present readiness, and we just get some basic data. How many health workers are there? What's the top 10 burden of disease? What's the population of the country? How many facilities and what kind of facilities are there? And we categorize them not by, is it a pharmacy or a lab or a, we categorize it by, is it big, medium, low, medium, or little? Because we're trying to stratify by cost, not by function. In workshop 2, we look at what kind of architecture are we going to adopt, and I very strongly favor a cloud architecture. And how many point of service solutions do we have now that the government is responsible for, and what types are they? Pharmacy systems, lab systems, electronic medical record systems, hospital information systems, and so on. Workshop 3, how digital ready are people? How digital ready are the facilities? Have they already got an EMR? How many point of service solutions, and are they already standards based, or are we going to have to put facades on them, or are we going to have to replace them? And in workshop 4, the elements of implementation science, like what is our capacity for implementation? How quickly can we go? How many years is this going to take? And then simple things like, all right, well, we're going to give everybody a health ID, a unique ID for health. Is it going to be a little card? Is it going to be a card with an RFID chip? Is it going to have your picture on it? All of these things have implications for cost and rollout, and we'll see how that works. So how does the spreadsheet tool create its cost profiles and its benefit profiles? It uses activity-based budgeting. So using the idea of the cards, I love this the most, by the way. This is the Brazilian card, and I have one. I was at some meetings in Sao Paulo, and I was meeting with some of the people from Siga Saúde, which is their health authority, and they were telling me that they can issue a card because they have 108 at the time. They had 185 million people in Brazil. There's more there now, but this was in 2010, I think. Instead of saying I'm going to have to do a big bang, give health cards to 185 million people, they just said, look, if you already have your card, bring your card. If you don't have a card, I'll issue you one in the next 90 seconds. And I thought that's amazing. And in fact, I a little bit impolitely said, really? And they proved it to be this is a real card. This is actually my Brazilian health card. By the way, they also have a wonderful thing in their constitution that says health is a human right. Your eligibility for care doesn't depend on being a citizen of Brazil. It's just because both your feet are presently in Brazil. So you're eligible for care because you're there. It's a human right. So if it's a simple pre-printed barcoded thing that you add, and you can handwrite it or type it. This one I was at the Ministry of Health, so it's typed. They can issue a card in 90 seconds because it's a pre-printed, pre-barcoded card, and it's cheap, cheap, cheap. So if they cost 5 cents each, which is about what these things cost, and you have 15 million people, then you just multiply one times the other, and that's how activity-based budgeting works. So leveraging this idea of a card, if they're $5 each instead of 5 cents each, then instead of it being 750,000, it's 7.5 million. Nope, it's 75 million. So something that costs $5 instead of 5 cents means this is 75 million instead of 750,000. Now, we drive the investment case based on how many of these things, how many of those things, what are those going to cost? And so you can make estimations around large scale versus medium scale versus small scale versus remote scale. And then you say, well, how many facilities of each type have I got? And the key is you don't have to be precise over any kind of 10-year forward-looking thing. You're not going to be exact. You don't have to be precise. You have to be not wrong. So close enough is perfect. And let's all agree, all models are wrong, but some models are useful. And the purpose of this 10-year investment case is to be useful, is to show whether this is going to work and it's going to be worth it. And now let's look at this that we're talking about. I get it. This is an eye chart at this point in time. This is the actual spreadsheet. You only have to enter information into this stuff that's green. And you have to put in things like the inflation rate. So the inflation rate, this is for Amalgaland. It's actually in our toolkit, we have an example, a worked example. And we picked information from, I think, 7 or 8 different countries and pulled it in to create Amalgaland. So it's real data, but it's not from any one country. So it's real data from multiple countries. So this is real information, I think, from Senegal, showing that was when we were looking at it before. This was the different kinds of facilities. So looking at the remote ones, the little ones, the district ones, and the ones in the main centers. And now we say, okay, this is how many of this type, this type, this type, and this type. So for a total of 6,716 facilities. I expect this to grow about the same rate as my population growth rate. So I should actually probably say this is maybe 2.5%. I have a little more than 15 million people in the country. My annual population growth rate is 2.6. I have 20,000 and a half health workers. And I'm going to say that my health worker population is going to grow at the same rate as my population is going to grow. And the inflation rate is the inflation rate. It's been high or it's been low, or you look at what the 10-year average is, and then you put a number in there and you say that's the the effective inflation. And all the other tabs feed into this summary that says I'm going to spend this much on governance, this much on data center, this much on the client registry, and so on and so on and so on. And all of this information comes from the other tabs. I started on the summary one because these data persist through all of the rest of the tabs in this big spreadsheet. And as you fill in this information, you start to get a 10-year horizon of investments to say, over the course of 10 years, I'm going to spend 125 million bucks. Now, it also gives some reality checks. So the toolkit investment case says, well, what is your total health expenditure per capita? Now, I'm going to let you look at that number for a second and compare it to Canada. Canada spends in US dollars about 7,000 US dollars per capita per year. This is an actual number from an actual country. So we in Canada spend $7,000 per year, and these guys spend $71 per year. The total health expenditure per capita is $71. So when I talk about working in some low and middle income countries, some of these low income countries are poor countries. And you have to be, you have to make a case for why somebody should spend $125 million over the course of 10 years when you obviously don't have very much money to spend on health. And that's what this is for, to make an investment case to say, well, yeah, but if you use digital health, you'll improve your adherence to care guidelines. And if you improve your adherence to care guidelines, you're going to have a huge impact on this, 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 and this. And they're the heart of your burden of disease. And all of them are good. And digital health can have a very significant positive impact on all of these. But here's a reality check. If that's your total expenditure on health, as a proportion of that, how much are you expecting to spend on digital health? And why that's important is in an OECD country, we would spend 3 or 4 or 5% of our total health expenditure on digital. And if this is going to be 11 or 15 or 20%, then it's a non-starter. But it's not. Look at this. After calculating all these things out, we're going to go through each of the tabs. It's less than 1%. And for a less than 1% of your total health expenditure spent on digital, you actually get your whole health system working more effectively. It's a systemic improvement. Let's quickly look at the other tabs. Again, this isn't intended to be an eye chart, but it's just to look at the governance side and to say you're going to have to set up a governance framework that's going to operate for the rest of time. You're going to have a national digital health strategy. And if you don't already have one, you're going to have one before you get started here. And you should refresh this every 5 years or so. So this is just a spreadsheet that says, if I refresh it every 3 years, then I can see what that is going to do to drive costs. If I refresh it every 5 years, then I can see how that's going to drive costs. And you just put the numbers in that if you have to bring in outside assistance, what do they cost? If you have to do regional meetings, how much do those cost? And it just basically is an activity-based budgeting way to drive what will be your costs over time. You can say you're going to stick build your own HIE and you're going to hand program it, and how many installers you're going to have and how many operators you're going to have, or you can just outsource it and say, I'm going to do infrastructure as a service, and I'm going to pay for it and procure it and then pay a monthly fee. That's what I favor, and that's what I'm assuming here. And this is somebody spending $500,000 and then $20,000 a month to have it operated. And that's for the IBM Fire Server, or for Smiles Fire Server, or the Google Health Fire Server, or something like that, where you would procure it and you would operate it, and you'd pay to have it hosted. The client registry. The client registry is interesting, and I'm going to zoom in a little bit here. But there's a few things that drive the cost. First, you have to be able to set people up. And so is there a digital ID provisioning cost? And maybe there is. If you're associating a PIN or something, it might cost something to set somebody up with the digital record. But then you also have your wallet ID. And I was, as I said, favoring the Brazilian one, where it's just a really cheap pre-barcoded card, and you can even handwrite and put it in a plastic sleeve, and for 5 cents you've got something that really is a very durable wallet ID. But they still have to get renewed. And so what's the renewal period? And then what's the churn rate? I mean, what percentage of the cards are going to get eaten by the dog or dropped in the river or whatever, and you'll have to replace them? So you just put these numbers in. How many facilities are going to be able to issue the cards? The great thing about the Brazilian one is you can say they're issued everywhere. Like all over the country, you can get a card, because you don't have to have a place that can create an RFID chip or take your picture and laminate it on plastic or whatever. So that actually makes it more approachable. It makes it easier to get these wallet IDs in the hands of your population. And then, if you're saying they're going to be everywhere, you still have to have a printer, you still have consumables. What proportion are going to need digital IDs and what proportion are going to need cards? Maybe you're able to leverage the national ID, and everybody over 18 already has one of those. So it might not be 100% that need the new digital IDs, maybe only a proportion of them. You put these numbers in and you see what the impact is in real time. Setting up a facility registry. The Interlink Facility Registry says, well, how many sources of underlying data do you have? Because the military might be operating facilities, the Ministry of Health will, of course, be. There could be faith-based institutions that are operating facilities. So how many underlying databases are there? What's the cost of each interface? Put in an annual maintenance fee for whatever that cost was. And then how many facilities do you have? And then again, how many interactions will the ministry have with each facility to make sure that the phone number is kept up to date and the contact person's name is up to date? And so how many interactions per year will the ministry have, and what will be the cost of that? Will it be by SMS message, a phone call, an in-person visit, whatever? And again, that drives costs. Very similar to drive the costs for the health worker registry. How many underlying databases are there? I always use the example, the College of Nurses, College of Dentists, College of Pharmacists, College of Physicians and Surgeons. You'll have multiple of these underlying databases, and then you have to have an interface to bring that content into the health worker registry. This is where you really spend the money, the shared health worker registry. Because firstly, you have to have connections into the shared health record repository from multiple digital health solutions. And again, this is just the ones that the ministry has to pay for. Maybe they'll pay for the private sector to get connected, maybe not. In Canada, we tend to give doctors money for their EMRs. We don't have to do that. In the United States, they don't give doctors money for the EMRs. They're expected to pay for it themselves. But however many digital health solutions it is that the ministry has to pay for the interface to the HIE, then that's got a cost, and then that's got an annual cost. Remember the facilities of, over 5,000 of the type 4, 1,250 of the type 3, 100 of the type 2, and 35 of the type 1. How many does for how many of these facilities does the ministry have to pay? Because if it's public and private sector, maybe the ministry pays for some and the private sector ones are on their own. What's the one-time implementation cost? What's the annual operating cost? What's the current adoption rate of ICT? So if they're at standing start for all of them, then it's zero. If you said that half the hospitals have already got something, you could say that 50% of the hospitals already have ICT implemented, then you only have to do the rest of them. And then you say, how many years is this going to take to roll out? And then again, how many Ministry of Health interactions will there be per year, and what's going to be the cost of that? And is it in person or over the phone or whatever? That drives the cost. And then this ends up driving over the course of the 10 years, your whole implementation profile for how much money you're going to spend on rolling out digital health all over the country. Terminology services, many of the terminologies that would be used in low and middle income countries will be free. SNOMED CT is a licensed product, but it's free if you're a low income country. If you're using the SNOMED IPS, that's always free. ICD-10, ICD-11, they're free. ICHI is free. LOINC is free. But it costs money to set up a terminology server, and you have to babysit it. And so I always have my clients model that by saying, look, you're going to have a one-time cost and a recurring cost. Even if the code set was free, you have to reflect those costs. And then how regularly is the ministry going to update all of the point of service solutions? And so that will drive costs because there's an interaction costs. How many times per year are you going to be refreshing the code lists used by all of the solutions in the network? Health management information systems. These are the analytics engines that your dashboard engines and so on. DHIS2, as I was mentioning before. Well, how many of those are there? How many interfaces do you have to have from the shared health repository to these analytics engines, and what's going to be the cost of maintaining it? And then are you still requiring reportable indicators to be submitted from every facility every month, for example? And what does that cost you? And so that drives costs. This is an interesting one because in many of these countries, in fact, in all of these countries, you have to build the health human resources. And as an initial cost, you have to establish data use education for all of your health workers. Well, what's that going to cost? Will you do some kind of in-class training, or will you set up an online training if you can, and then annual refreshers? I helped establish the first health informatics program in Ethiopia. We had to have money to establish that in the largest university in Ethiopia, they had a health informatics program, and they could operate that. So this is where you would again use these as the activity-based cost drivers. All right, I'm going very fast here. This is where you go from costs to benefits. Now, the WHO for years and years and years has had the idea that if you can get a quality adjusted life year, or if you can avert a DALY, but if you can get a quality adjusted life year for 3 GDP per capita, 3 times the GDP per capita, that's a good buy. If you can get a quality adjusted life year for less than 1 GDP per capita, that's a great buy. And what we're actually establishing here is the cost effectiveness threshold. When is this worth it? And we would say it's worth it when it's 1 GDP per capita or less in terms of our cost. So if we're averting a DALI for less than 1 GDP per capita, that's a great buy. That's a terrific purchase. And in terms of economics, and World Bank is absolutely lousy with health economics professionals. In terms of economics, the World Bank has always believed this, that the gross domestic product of a country isn't something that exists on its own and it gets divided into the population to go per capita. It's the result of the people. So if you have a healthier life year, you are a stronger contributor to the GDP, because that's what GDP is. It's the gross domestic product that we all contribute to, and we contribute more when we're healthy. These are actual numbers from Senegal. I do know for sure. This is what the DALIs are per year lost due to malaria, 368,000. 151,000 life years lost to ischemic heart disease. 890,000 lost to neonatal disorders, the things that are addressed by childhood immunization. 424,000 life years lost to diarrheal disease. Now, these are not deaths. These are life years lost. A DALI isn't a death. It's a life year lost. And lower respiratory infections, that's influenzas, 328,000 life years. Here's what that means. Our target for quality adjusted life years that we can recover by improving malaria care. By the way, malaria, you get all of them back. If you follow your malaria treatment, you cure malaria. You treat it down to zero. But this is 2.1 million quality adjusted life years that we can get by improving effectiveness of care. We put in the lead time. How long do we think it's going to take before we start enjoying benefits? Remember, I talked about critical slice implementation that could maybe shorten the lead time. But if we think back, we were saying it was going to take 4 years to roll out all the digital health. Well, I'm saying I'm not going to get anything for 4 years. And then I'm saying my benefit realization, I'm going to make a 1% impact. Now, let that hang in the air for a second. 1% is sort of the smallest amount of impact you could possibly have. For malaria, if we actually adhere to the care guidelines, you eliminate the malaria. And I was involved in a malaria elimination project in the Mekong, in Vietnam, Cambodia, Laos, and Myanmar. We're trying to eliminate it, meaning the benefit realization target was 100%, not 1%. But 1% is sort of the smallest amount you could possibly measure. Here's why I'm saying all of this. With all of the costs that we were putting in and the cost effectiveness threshold that we established, over the course of, and this is, I think, as I said, Senegal, but I'm not positive, you don't realize any benefit for the first 4 years. And on a running cost per quality basis, meaning that you have to get all of your money back for all of the things that you spent in the first 4 years and all of your operating costs, you immediately start getting benefit. And by year 6, you've recovered every penny. And by year 10, the economic value of an investment in digital health is that you get $2 back for every dollar you spend. And if we said that this was 5% instead of 1%, and keep in mind for some of these, the randomized control trials indicate you can have a 25% or a 35% impact. But if I said I'm going to get 5% instead of just 1%, the cost effectiveness is at 1. Well, let's just skip right to year 10. I'm getting $10 of return for every dollar I spend on digital health. And this is a low-income country. I'm going to leave it at that. I had one more thing I want to show. I know I've run us over time, but this is the one more thing I want to show. You're in a program that is improving your abilities as a professional. So you're investing in your blue circle in this Venn diagram. You're investing in what you do well. My career advice to you is find the overlap between what you do well, what the world needs, what the world will pay for, and what you love, and make your way to the center of this Venn diagram. And I can tell you, I've spent probably the last 18 years in the middle of this Venn diagram. I worked for a long time in supply chain management and industrial engineering, but I've worked for the last 20 years or so in digital health. And I get to spend my workday in the middle of this diagram. And my career advice, not that I was asked to give any, make your way to the middle of this diagram. And Linda, that's the end. I don't have more.
And that, my friend, is why you may never retire, isn't it?
I am very mission driven. The truth is, It is what I love. I've told my kids I'm not going to take up woodworking like their Uncle Bill. So if I decide to do health informatics as my hobby when I retire, that they shouldn't be judgy.
Exactly. Exactly. Some of us enjoy what we do, and yeah, that's the best place to be. So hopefully Debbie, Diana, Justice, and Laura Lee can relate to that and yeah, follow that advice. Good advice. Thank you very much, Derek. Really appreciate that presentation. There was a lot of information there. I'm going to ask the team for their questions.